Right. Good morning, everybody. I am Dr. Ashish Nabar, part of the EC of the Indian Heart Rhythm Society and coordinator for this Indian Heart Rhythm Society DNB arrhythmia teaching program. This is a nice initiative taken by the EC led by our president, Dr. Yash Lokhandwala. It's a monthly program, once a month program on the first Sunday every month. And we believe it helps a lot of DNBs who attend this meeting. Well, it's not too late to wish you all a very happy Diwali. I guess the festivities are still on, but as we progress through this meet, we will have more and more people joining us and interacting with us. So that's definitely. And before I start with the today's program, let me remind you about our 13th annual conference, which once again is online. It's the Digital IHRS 2021. We have a huge faculty and a very expansive, detailed program. The Theatre 3, especially for this group, is meant for the non-EP cardiologist and the cardiology postgraduates. So I invite you to register for this meeting. You already have received emails, and we should have you in the Theatre 3 attending to all these programs. Of course, all the theaters are open to everybody who registers. Coming to the today's program, again, we always have a discussion with the host faculty as to what would really suit the attending audience. And this time I heard a word with our past president and host faculty for this program, Dr. Anil Saxena and Dr. Aparna Jaswal, both from Fortis Escorts in New Delhi. And they thought it was wise to teach something about pacemakers. So there are different aspects of pacemakers which are being dealt with by the two host faculty and fellows from their department. Everybody will introduce themselves before they speak, so I need not waste time on this. Importantly, we have two experienced moderators, Dr. Asit Shah from Jaslok Hospital, Mumbai, and Dr. Anis Tajuddin from Kerala, both senior IHRS faculty, and they will chip in with their comments and synchronize this whole teaching in a good way. So without spending much time on this, I will request Dr. Aparna Jaswal to set the ball rolling. Aparna.
Thank you so much, Dr. Ashish, for giving us this opportunity to be here with the young of the country and the budding electrophysiologists. And I think the plan for today was to cover pacemakers in its completion, and the whole program is being led by none other than Dr. Saxena. So each one of us will cover these topics, and without spending much time, I think the format is that we have very distinguished, very accomplished fellows with us, Dr. Shafiq and Dr. Amitesh. They will be presenting two interesting cases that we have done in the recent past. I will touch upon pacemaker timings, for which I think I actually need you to give me an hour. But for the constraint of time, I will try and justify. And of course, Sir will come in with his ECG rhythms, and Sir will lead the entire program because we are very fortunate to have him with us today. So I think we'll request Dr. Shafiq to start this case, and then I will come in, and then Amitesh, and then Sir. Please, Shafiq, share your slides, and please be unmuting yourself.
I would request all the attending audience to mute themselves so that we have least disturbance as the speakers go ahead.
Yeah, good morning. Good morning, ma'am. Can you hear me?
Yes, we can hear you. And can you please make it full screen, the slide?
Yeah. Yes. Should we start?
Please.
Yeah. Good morning, respected teachers, dear friends. My name is Dr. Shafiq Zargar. We'll be presenting the first case. Our first case was a 90-year-old hypertensive female. She presented to us 3 days history of typical angina on effort. It was NYHA class 3 and it was associated with shortness of breath. There was no history of any cough or any fever. When we first investigated her, we did her ECG, which showed an arrow QRS sinus rhythm. There were subtle changes in the inferior. You can see there are QS patterns in lead 3 and lead AVF with some subtle possibly an acute inferior wall MI. So we went ahead and did an echo, but it did not reveal any renal wall motion of normality, and her normal, her LV systolic functions were normal. We did a cardiac troponins and they were also normal. So we basically managed her as an unstable angina, and subsequently she underwent an angiography which showed a double vessel disease. Her RCA was normal, but she had a focal lesion at the LCH-OM bifurcation and in the proximal LAD. And both of the two vessels were successfully stented. Her LCX and both LAD were successfully stented. The post PTCA for a couple of days, she was fine. Only thing is that she dropped her hemoglobin because of a local groin hematoma from 12 to 9.8. But on third day post PTCA, when she was in her room, we got a call that patient has had a syncope and a fall in the bathroom. A subsequent ECG of this patient showed an AF with fast ventricular response. We can see again there are subtle QS in inferior, but no overt ST elevations. So there was just a fast AF response. She was shifted to our ICU setup where she was given a 150 milligrams of amiodarone IV bolus. So when the amiodarone IV bolus was almost halfway in, the patient developed sinus arrest after this AF termination, which caused syncope. So this is our central monitor there, which showed a very long pause happening. The pause was roughly around 8-9 second long pause after the AF termination, which caused syncope. Immediately, the patient was taken back into the lab. She underwent a temporary pacemaker. We were worried. What was the status of her stent? Our coronary team was worried about that. So they did a check angio, but LAD, LCX stents were patent. And subsequently, over next day, when finally patient with almost a diagnosis of a sixth sinus, so of a tachycardia of a sixth sinus syndrome, she underwent a dual chamber permanent pacemaker. During the pacemaker, lead, but when it comes to RA lead, we struggle a lot in getting the right parameters in this patient. She was a 90-year-old female, probably scarring and all that. We searched almost whole of the right atrium, the lateral wall, the whole of the appendage. We spent a lot of time getting the right parameters, but we were not able to. So finally, we stopped that at a P wave of 0.9 millivolts. Our P wave was 0.9 millivolts, the amplitude of the P wave, and our thresholds were also by the end of procedure slightly higher. 2 volts was the capture threshold at 40 milliseconds of the pulse width, but our RV parameter, RV lead parameters were fine. The next day, after next day on the procedure, what we did again and interrogated the patient, her P wave further reduced from 0.9 to 0.4 millivolts, but her threshold improved from 2 to 1.2 volts. Her threshold improved, but the P wave amplitude reduced. On the second post-procedure day, we did a routine ECG, and this was the ECG of in this ECG is what is happening is that we can see there are coming and there is a narrow QRS rhythm. So patient spikes seem to be appearing and they seem to be ignoring the intrinsic QRS rhythm. So quite clearly undersensing is going on. We can see that the patient spikes seem to be coming with variable AB intervals. So it appears that this atrial undersensing is happening and there is a conduction also. The patient has a native conduction and there is atrial undersensing going. So with atrial undersensing in mind, we underwent and interrogated the device. And once we interrogated the device, atrial annulations are present. So there is total atrial undersensing going on. The atrial EGM may show some spikes, but that is because of very high gain. As you clearly see, the sensitivity has been reduced even to 0.15 millivolts, and still hardly any annotations of atrial markers are seen. So there was a total atrial undersensing going on. So while we were checking ahead, what I personally saw was that there were a lot of patterns start to be appearing on the screen. So I was interested and we did a couple of more ECGs of the same patient. So before I go there, I want to say that despite atrial undersensing, when we check her capture threshold had even became better. So right now the capture threshold was 0.75. So capture threshold was 0.75, but there was total atrial undersensing going on. This is the ECG which we did at that moment in time, which again showed a very, very interesting finding. As we clearly see in this ECG is that the atrial undersensing is still going on. It's totally ignoring the intrinsic P wave and giving an H spike. But what is happening here is what interested us. So let me tell you, the patient had a dual chamber. Right now it was working in the AIM mode and the MVP mode was on. So what we see here is what happened is that they're quite clearly because of the undersensing, it has delivered a spike here. And once it has delivered a spike here, obviously it won't conduct because it has caught the V in the refractory period. So it won't conduct. So what the device will sense, this A spike will as a failed conduction. So immediately when it senses a failed conduction, it has delivered an A spike and an A pace and a V pace at the interval of 420 seconds. So this is what is called as a safety A pace, V pace done by the pacemaker when the pacemaker is in MVP mode. So in order to explain it better, let me tell you, so this is the same thing, the marker showing here right now, the A pace is happening. It has not sensed any V, so it has taken it as failed conduction, and it has delivered a safety A pace, V pace because the MVP mode was on. What is basically MVP mode? So basically MVP mode is a mode that is there then promotes the normal intrinsic AV conduction. It primarily acts in an AII mode and continuously keeps on checking whether AV conduction is occurring or not. And in any case, the AV conduction fails and the criteria of AV conduction failure are met, it will switch on to the DDD mode. And then it will regularly keep on checking the AV conduction. And once it feels the AV conduction has restored, even for a single cycle, it will switch back into the AI mode. So this is simple what managed ventricular pacing algorithm is. So basically, what has happened in the previous, which was MVP 1.0 mode, what used to happen is that, so if A pace or an A sense did fail to conduct, so it dropped, so it will wait for the next atrial event in the form of an A pace or an A sense, and then it will deliver the safety pacing, the escape pacing, a V pace at an interval of around 80 milliseconds. So what would happen is that one A pace or one atrial event will always get dropped. So that would lead to a reducing of the ventricular rate to the half, and often it was reviewed back that this pause may even be symptomatic in certain patients. So this is what they have changed in the MVP 2.0. In MVP 2.0, they will never let the ventricular rate drop to the never let the ventricular rate drop to it won't if, let's say the patient was pacing at a rate of 60, it won't go to 30. Before it, what has happened is that in the MVP 2.0 is that if any time the device's senses an atrial event has not conducted, either an A pace or an A sense event has not conducted, or what will it do? It won't wait for the next atrial event. No, what it will do is that immediately after a certain time limit, which will work on the algorithm, it will deliver an A pace and it will deliver a V pace at 80 milliseconds interval. So that's exactly what is happening here. So the device here has basically picked that this atrial event has not conducted, and within a 40 milliseconds, it has delivered an A pace and a V pace at an AV interval of 80 milliseconds. So this is a backup A pace, V pace happening in the MVP mode once the AV conduction falls, which basically was not supposed to happen in this case. It's just happening because the atrial is under sensing. So that is to be kept in mind. So this is a pseudo malfunction happening because of a true malfunction, the complex interplay between the two. So that's what we were trying to show here. So then this was very important. So that's what has happened basically. And has happened one. So second important thing, so then we subsequently were again interrogating the same patient, and we wanted to check the parameters in DDD mode, and again a very interesting pattern started to appear. What we see in this pattern is that, although we do not have the ECG of this pattern, what is happening is that after an atrial sensing, the device is giving an A pace, and very coincidentally, his own native QRS is getting sensed right very close to the A pace in a time interval of 110 milliseconds. The device is taking this as now as a crosstalk and is delivering a ventricular safety pacing immediately 110 milliseconds. So here a ventricular sense event is not inhibiting, that this algorithm is called as ventricular safety pacing. Basically, ventricular safety pacing is an algorithm that gets activated in a dual chamber pacemaker in a DDD mode whenever an atrial pace occurs. So whenever an atrial pace occurs, the next 110 milliseconds, it will keep on tracking that interval, and if any ventricular channel sense anything, it will be taken as a crosstalk, and at the end of that 110 milliseconds, it will deliver a V pace so that if the patient is dependent patient, he won't go into an asystole. So this is the basis of so the main reason was the crosstalk. But in our case, the ventricular safety pacing was occurring because of atrial undersensing, and that was causing a coincidentally the VS to come very close to the A pace. So these are the common three causes of ventricular safety pacing. Basically, it's meant to crosstalk. It can happen in late, it can happen in atrial undersensing as it was happening in our case, and it can even sometimes happen if a very late PVC comes in the blanking period and then in a cross detection window, and then it can cause. So this is, let me show it diagrammatically if you can see it. Let me just take it here. Yeah. So what happens after an A pace? There will be an AV interval, then there will be a V pace. Now this AV interval will be divided into first part of the AV interval will be a total blanking period. We can go up to 50 milliseconds, and this post atrial ventricular blanking period, nothing will be sensed. Then there is a crosstalk detection window which extends up to 110 milliseconds. So this crosstalk, any event which gets sensed in this on the ventricular channel, which gets sensed in this period zone, will be taken as crosstalk, and the device will be worried whether it's a true conduction or not. And at the end of the 110 at the end of this 110, it will deliver a V pace. So any sensing in the ventricular channel in a crosstalk detection window will not inhibit, rather it will trigger a ventricular event at 110 milliseconds. So that is what the crosstalk is basically. And in our case, the crosstalk was and both MVP modes were both occurring not because of a true algorithm, but they were as pseudo malfunctions occurring because of an underlying atrial sensing. So we can see in our case a very complex interplay of algorithms, all because of atrial undersensing. That's what we wanted to show in this case. And finally, so how did we manage? So I think the best way of managing our case would have been taking her back to the lab, so repositioning the atrial lead. But in our case, so we were dealing with a female. She was a 90-year-old female. She had a very difficult 1 week. She had MIs and she had local groin hematoma. I didn't tell you, she even had a transient TIA during because of she was having that AF episode, she had a transient TIA also. So it was decided not to take the patient back to the lab to reposition because her atrial thresholds were pretty good. But we did it, we put her in a committed pacing mode at 80, and this atrial undersensing totally gone because we put it in a committed atrial pacing, and gradually the plan was to beta blocker so that we can reduce the lower rate to around 70. So that's what we did. By the end of discharge, her lower rate was brought down to 70, and that's how we manage the atrial undersensing. And in this case, we showed how this atrial undersensing can play with the complex algorithms and cause unnecessary spikings, unnecessary pacings, unnecessary mode shifts. And that's what we all wanted to show you. Thank you very much.
Yeah. So thank you so much, Shafiq. I think at the outset, there was a question as to why do you not give a VVIR pacemaker, which I think is a very well appreciated point, and we have to remember in extremes of age, we do opt for that. In this particular patient, as I just wrote, she was elderly and she had a very bad acute LVF episode, and her NT-proBNPs were elevated. She was having previous history of syncope. Given the face of all of that, the thought was that let us give her an atrial-based pacing. That was the reason we did that. So thank you very much, Shafiq. I think that was a very good case, and we are open to discussion. I will request everybody to please mute themselves.
Dr. Asif, you want to come in?
Yeah, just a couple of things. I have at least the MVP mode doesn't work so well in patients who have a first degree heart block, a seriously prolonged PR, 300, 350, or a patient who's Wenke bucking. They invariably complain of symptoms during the pause at the time of Wenke back. What would be your experience or your thing with that? Do you really try to do a MVP on when a patient has, let's say, a suprahesion conduction block with either Wenke backing or a severely prolonged PR interval?
Yes, so you're absolutely right. So that's what we're trying to explain is that in an MVP 2.0, this problem has been corrected. So that MVP 2.0 will never allow. So they have introduced two new features in MVP 2.0. One is that it will never allow the A pace or an A sense to drop completely. So what will happen is that we can always have a maximum AV limit in an MVP 2.0. So what it does in MVP 2.0 is that it always calculates the AV interval of the last 4 beats. So let's happen in this case, it's already seen that 313 is the average of the last 4. So anytime the AV interval goes beyond 313, it won't wait for the A to get dropped. But since it is 313 will be the average, so at 413 milliseconds, so as soon as the AV interval go to 413 milliseconds, so you have to add 100 to it. It is 313 and you have to add 100 to it. So 313 plus 100 will be 413. So after any A pace or an A sense, after 413 milliseconds of an AV interval, it will deliver and an A pace and a V pace at an 80 millisecond gap. So it will never allow the pause to go beyond. That is what they have connected in MVP 2.0, and that's what we were showing in this case. It was a Zoom device which shows and which has MVP2 mode in it. Yes.
Can I come in here? Dr. Asit is completely right, but actually the the picture that the illustration that Shafiq has shown in the previous slide, there the PR interval appears to be long. You're completely right that whenever PR interval is long or the patient has frequent second degree AV block, we do not, it should not be switched on. It's only for patients who have a normal PR interval and have intermittent, occasional complete heart block lasting, like having Stokes Adams attack. So at that time, patient can have MVP, can help us minimize the, RV pacing, unnecessary RV pacing. But the disadvantage of MVP mode traditionally has been that sometimes if subsequently the patient develops Vanke-back AV block or frequent second degree AV block, they used to come back to OPD with symptoms that I often feel lightheaded and dizzy and all that. And when you check, they have we were seeing frequent episodes of bradycardia related to the MVP operation. So that probably Medtronic have updated the algorithm for that reason, that they don't allow the PVF to drop completely, rather it just leads to a prolongation of the PR interval for that 1 beat or 2 beats, and patient doesn't feel much symptoms. But absolutely, I completely agree with you that if patient has pre-existing, like in this example, if the patient has a prolonged PR interval or a pacing particularly, that we should, maybe we can keep it off. There's always a debate as to what AV delay we can allow for native conduction. And usually the cutoff that is advocated is 250 milliseconds. The patient after A pace or A sense has a 250 milliseconds AV delay, we can allow native conduction, we can prefer native conduction. But if it's beyond that, then certainly it's better to normalize the AV delay by A pace, V pace, or A sense, V pace.
Absolutely.
If you allow me to just come in for 1 second. So what Dr. Asit said was very, very right. That patient has a first degree heart block and you've given a pacemaker. The reason you've given a pacemaker to a patient of first degree heart block is because he's symptomatic because of that first degree heart block. Now, in that patient, keeping the MVP on completely destroys the reason for giving him a pacemaker. So as I think this goes, that we have to understand, as Dr. Saxena also just made a point, that when you're trying to treat patients, which is a small population, but if you're trying to give a pacemaker for first degree or a Mobitz type 1, we have to remember MVP should be off. Otherwise, it is of no use in that subset.
Absolutely agree. Just for the sake of our postgraduates, could you just tell us how you would implant a dual chamber system in a patient who's in AF when brought to the lab? If you have paroxysmal AF, but when you bring to the lab for a pacemaker implant, patient is in AF. How will you position the atrial lead? Because there is a lot of thinking ki arey, patient is in AF, do a single chamber VVIR or something, finish it. But we should attempt all the while to do a dual chamber to provide AV synchrony and its usual obvious advantages. So could you tell us how you would do that? Atrial lead positioning in AF.
Yeah.
So
Aparna.
Yeah, so basically, I think I would also want more inputs from Dr. Saxena. But basically, when you take the patient in the lab, sometimes the patient is in sinus, has good peace, but as soon as, in fact, you put the atrial lead, the patient goes into atrial fibrillation. So what you must do are a couple of things. Surely you cannot check the thresholds of this patient. What you must see is that you must get a P wave of at least 1.0 millivolts, because you should not accept very lower millivolt P waves, because then it can result in atrial undersensing. And if you strive a little, you will get it. Second, I think it's also the anatomical positioning which is really valuable here. You must want to enter the appendage, and you must want to see the motion of the lead in the appendage very well. Now, here is a point that you can still depend upon a slew, but you cannot check the current of injury and you cannot check the thresholds here. So these two values will not be on your side, but trying to achieve a good threshold and trying to see for a slew will make sense. In a normal pacemaker, in a normal sinus rhythm, when we want to see the P, we do not accept a P wave value less than 1.5. So you can come down lower here, even 0.9, 0.8. You must see the slew. Slew is change of voltage over time. We always strive in an atrial lead to have a slew of more than 0.5 to 1. So these are two values. Third, you must look for a good movement of the atrial lead in the appendage, typically as it is explained like a car wiper. If you are not getting it, you can strive to go to the lateral wall of the right atrium with lot of caution. The right atrial lateral wall is the thinnest part of the right atrium. And if you are using a screw-in lead, you have to be very cautious when you're screwing it. Immediately pull the stillet back after your screw is out, and do not push the lead with your stillet in. Over to you, sir, Dr. Saxena.
Yeah, I would just add one more point that in some patients, you can plan to cardiovert in the lab. Like Dr. Asit is saying that if the patient is in atrial fibrillation, you can discuss with the family that I plan to cardiovert. And in that case, you must rule out LA appendage thrombus by doing a TE on the morning, same morning, and then take the patient to the lab and cardiovert, and then proceed with your procedure. Without ruling out LA appendage thrombus, it would be difficult to cardiovert because patient, unless we know that there's no thrombus. So then we can proceed with, as Dr. Aparna has mentioned.
Right. Just one more. Oh, sorry. Okay, Ashish. No, I was just thinking, what is your experience with the AF prevention algorithms, which are there, or atrial high rate algorithms?
It has been studied in that Minerva study, and we are also doing one study in India currently. There is some benefit to these patients by ATP. I mean, some pacemakers do have reactive ATP, and they can benefit. Overdrive pacing preference. We have had a couple of examples where the patients benefited, but it's not really proven. And one thing is certain, that we don't recommend pacemaker for intermittent atrial fibrillation for AF suppression. That is complete as a class 3 indication to advocate pacemaker for paroxysmal AFib to suppress paroxysmal AFib. So that is not done. But in patients who have ready requirement, we can certainly utilize these algorithms to minimize the duration or AF burden or whatever. But it can certainly help. More helpful is the automatic mode switch in AF patients, that patients who have intermittent atrial fibrillation, the pacemaker can automatically sense atrial fibrillation and go to a VVIR mode or DDIR mode, whichever we can program, and that can be more helpful.
In the ESC 2021 guidelines, utilization of these algorithms is still a class 2B indication.
Yes.
Okay.
I think Aparna, you should start here.
So I think we'll have to stop sharing our screen, please. Is my screen visible?
Yes.
Yes.
So thank you so much. And I think I'll quickly move on. And I think the stage has been set for us to move into this pacemaker timing cycles. And as I just mentioned, this is something which actually is a symposium in itself, but I will try and justify in the time allotted to me. So the pacing cycle is a time between two consecutive events either in the ventricles or the atria. And the timing interval is any portion of the pacing cycle that is significant to a pacemaker operation. It could be an AV interval, it could be ventricular refractory period, it could be atrial escape interval, it could be TAR. We'll discuss all these points. These are the subheadings in which I will walk you through the presentation. And before we move in, I think it's a point that we do make a point about the NBG pacing code. It gets its name from North American Society of Pacing Electrophysiology and British Pacing Electrophysiology Group, generic pacemaker code. Now it's called the NBG code, and this was first conceived and proposed in 1974. But these accomplished, acknowledged electrophysiologists came together and actually gave it a shape, and the code came into practice in 1987. It was revised by most of the same people in 2002. Just a moment here. So I always tell my fellows, why are we giving a pacemaker? It is to pace. The first letter is for the chamber paced. The second is for the chamber sensed. The third is what is the response to sensing? Does it inhibit itself or does it trigger? It typically inhibits itself in a single chamber pacing mode, and it triggers itself very seldom. We don't use a triggered mode. When do we use a triggered mode? When we are using a dual chamber pacemaker. So when there is a P synchronous pacing, the atrium sees the P, inhibits itself and triggers an AV interval and then paces from in the ventricle. Of course, the rate modulation pacemakers are the ones that we use today when we are giving a triple DR or a VVIR, and how it does rate modulation given to the patient's level of activity. Multi-site pacing is what many of us are engaged in doing, be it a CRT, be it a hot CRT, a lot CRT. So that's the letter 5 which comes in. You must always look at the pulse generator when you are implanting. So when you are giving a CRTP, it will be written DDDRV. So you should have a look into the pacemaker. The terminology of single chamber pacing is, it could be lower rate interval. Lower rate, it is the interval corresponding to the programmed lower rate. It defines the lowest rate the pacemaker will pace. It starts after every paced or a sensed event. It ends at a paced or a sensed event. As you can see here, it can be either a VP-VP as is, or a VS-VP in a VVI pacemaker, or similarly AP-AP and ASPP-AP in an AAI pacemaker. So chamber paced, chamber sensed, response to sensing. As you can see, a lower rate is 60, and always in pacemakers, we use it in milliseconds. Now, interval initiated by a paced or a sensed event. What is the refractory period? It is designed to prevent inhibition by cardiac. This you are seeing, there is a cardiac or a non-cardiac event, and there could be many reasons for that. It could be a stimulus evoked R wave, repeat sensing of the same intrinsic R wave, T waves or noise. The events which are sensed in the refractory period do not affect lower rate, but they start their own refractory period. So this is very important to understand, that when there is a sensed event in the refractory period, it begins its own refractory period. It does not change the lower rate interval. You can see this came in, but nothing happened to the lower rate interval, although it was sensed refractory. It can be written SR or VR or AR. Blanking period. Now, this is also very important. The first portion of every refractory period is the blanking period. The pacemaker is blind to any activity and no events can be sensed. However, we have to remember that sometimes you may interrogate your patients in atrial tachycardia and you can see there can be an AB written. It means atrial blank. The newer generation pacemakers can see even in the blanking period to pick up and go into mode switch. They are designed to prevent oversensing of the pacing stimulus and an after potential. So whenever there is a pacing stimulus, there is a hyperpolarization, there is an after potential, there is a trailing edge. You don't want to pick up the trailing edge of the pacing spike. And for this reason, these intervals are programmed. What are the rate response sensors? There are several, which I don't want to get into, but we have to remember that the basic pacing rate in all rate responsive modes, it is determined by the pacemaker based on the sensor detected level of patient activity. So meaning thereby, if the patient's motion sensor tells that for that level of activity, it has to be higher, it will immediately go there. So the low rate is less than or equal to the sensor indicated rate, which is less than or equal to upper activity rate. One point I wish to make a mention here is that the pacemakers never violate their the rates that we tell them. They are taught to be in that rate, and they will never violate. They will adjust such the other intervals so that those rates are not violated. So somehow I'm not able to see on the top. No, the upper heading I'm not able to see anyway. So what is the sensor indicated rate? It defines the shortest interval the pacemaker can pace. This upper sensor rate interval is the shortest interval the pacemaker can pace as dictated by the sensor. So this is the sensor indicated rate for that given activity at that point in time. But if the patient was to walk uphill, the upper sensor rate interval will tell him that it can go higher, and this is the shortest interval it can pace, or the highest rate the pacemaker can pace detected by the pacemaker. Now, these are certain modes which we see. Now, VOO mode is basically hardly ever seen. VOO mode is an asynchronous pacing mode. We hardly ever leave our patients in a VOO mode. It only typically would be done in nowadays in an operating room, or if your patient is pacer dependent and you're wanting to tide over some crisis if there is over sensing taking place. So what happens in a VOO mode, as you can see, there is an intrinsic event, but this intrinsic event is not sensed at all because it is blinded to any activity. The pacemaker has been taught to see nothing else. So in the NBG code, it is only supposed to pace. It is not supposed to pace none and response to sensing none. So that is what is called a VOO mode. This activity goes unnoticed. What happens in a VVI mode? Now, chamber paced, chamber sensed, and if it senses, it will inhibit. So this is the lower rate interval, VVI 60. This is the ventricular pace. It initiates the lower rate interval. However, before the termination of the lower rate interval, there is an intrinsic activity takes place. This intrinsic activity is sensed as we sense. It initiates a blanking period followed by a refractory period and also begins a lower rate interval. At the end of the lower rate interval, it will give a spike if it does not sense any event here. So this is how a VVI is in operation. This is a ventricular pace. Before the timer, there is a timeout of its lower rate interval. It has sensed a ventricular sense. As soon as it senses, it initiates the lower rate interval, and at the end of the lower rate interval, it paces again. However, what is happening here, you should see. This is a V sense. It sensed appropriately. It was outside the refractory. Hence, it initiated the lower rate interval and it paced. Now, this is something which is happening here, and it sees it as it has detected that there is some activity here. It is seen as ventricular refractory because it has come in the ventricular refractory period. Because it has come in the ventricular refractory period, it will not reset the timer. So it has not reset the timer, unlike the non-refractory sensed event. However, every time there is a sensing of an event, it begins its own refractory period. This is important to understand for the noise reversion mode that you may want. Supposing there are a lot of ventricular refractories, it can go back into the noise reversion mode. And that is the basic operation mode of the timing intervals in a VVIR, as I have just discussed, and the same thing happening in an AAIR when you have an atrial based pacing allowing for the normal AV activation to sequence the blanking and the refractory in the atrial channel. Now, this is something which is very important, and hysteresis is worth a discussion, especially when you will see patients who are implanted a single chamber pacemakers, and we in our clinic use this very much in the pediatric population, because the VVI pacemakers in our large subset are in the pediatric population. And what does hysteresis mean? So we just mentioned that a VVI, it never violates its lower rate interval. A V pace at the timeout of the lower rate, it will again give V pace. However, if it senses an intrinsic event as a V sense, it changes its lower rate interval so as to promote intrinsic conduction. So while the lower rate interval was 60 beats per minute, the hysteresis rate is programmable. You may even want to make it lower. You can make it 40 beats per minute. What does that imply? That means when it senses an intrinsic event, now it will wait for a longer time for an intrinsic event to come. If it were not to come, it would pace this, give a V pace and pace it. Supposing there was an intrinsic event at 50, then it would further wait another for the next beat also for up to a rate of 50 before it would go into V pace. That is what is hysteresis. Hysteresis is a mode which is largely done to promote intrinsic conduction, wherein we don't want to V pace. You must switch this hysteresis rate on in children or even in other individuals who have a VVI pacemaker so as to promote intrinsic conduction. So dual chamber timing, DDD or a universal mode. I think Dr. Saxena sir will also discuss this, but just a quick mention, it can have 4 phases. It can either be AP, VP, it can be AP, VS, it can be atrial sense, ventricle pace, or you could have a dual chamber pacemaker with AS, VS if the patient is having good intrinsic conduction. And in fact, we should strive, because we are aware that even those patients who are in complete heart block, in about 20 or 30% of them, you could very well find that they resume their intrinsic conduction. And that's when the discussion took place in the last case of managing ventricular pacing or minimizing ventricular pacing. We all should strive for this even after we've given a pacemaker. So the timing intervals when we are talking of dual chamber, lower rate, AV, VA, I will just walk you through these. So lower rate interval, the lowest rate, the pacemaker will pace the atrium in the absence of intrinsic atrial events. What does that mean? That meant that if there was an AS here, it will reinitiate the lower rate interval. However, if there is no event, this is the lower rate interval at a rate of 60. It is the lowest rate the pacemaker will pace the atrium. It will be AP-EP or an ASAP. It starts with every atrial event and ends with the next atrial event. What is an AV interval? Now, AV interval is an electric analog of the PR interval. It allows for the atrioventricular synchrony, and this is a very important interval which should never be overlooked, because this is where you are looking for the completion of diastolic filling. It should neither be too long or too short. It is initiated by a paced or a non-refractory sensed event. So either a paced or a non-refractory sensed event. The atrial channel is refractory during the AV interval. Actually, the atrial channel, I will just show you, is refractory for a much longer time. But the atrial channel is refractory during the AV interval. Now, why are these red lines here? This red line is here because the lower rate interval would have waited this long to give an A pace if there was no non-refractory atrial sense. So this is an atrial sense which has come in. Because this has come in, the lower rate has been abbreviated and the AV interval has been initiated. At the end of the timeout of the AV interval, it gives a V pace. There is a difference in the programming of a sensed AV and a paced AV delay. And why is that so? So sensed AV delay, we program it lesser, while the paced AV delay is always programmed more. The rationale, there are several reasons for the same, but what is simplest of all? When there is a sinus node depolarization, we are much aware that there are specialized, we know there is a Bachmann's bundle running on the roof of the right atrium to the left atrium and terminating at the lateral wall of the left atrium. Sinus node depolarization is carried by specialized internodal tracts, and by the time this impulse is sensed by the pacemaker lead, some time has already elapsed. Hence, the SAV is lesser than the paced AV delay. This is one thing which we should always remember and know. So after the expense of the AV interval is the initiation of the atrial escape interval. It is the interval between the paced or a sensed ventricular event to the next atrial event. It starts with a VS or a VP. It ends either with an AP or it may end prematurely, as the previous I showed you, with an atrial sense. So lower rate interval you are seeing is this. This is a VA interval. This is a non-programmable VA interval. It is calculated by the pacemaker in itself, after taking in account what is the lower rate interval that we have set and what is the AV interval that is happening, because the patient could have intrinsic conduction with A-pace, V-sense, and it will program in itself the VA interval depending upon the lower rate and initiate the next A-pace depending upon whether the patient gets an intrinsic. If it does not, then this is the VA interval. So the lower rate interval, this is the VA interval. Now what has happened? If you look here, while there was a V-pace, it initiated a VA interval. But the VA interval got abbreviated by a non-refractory sensed event. What was this? This was a PVC. So whenever there is a PVC, this PVC will now initiate a new VA interval. At the end of this VA interval, it will then give again an A-pace and a V-pace. So that's how the atrial escape interval works. Now, you have to understand what is the upper tracking limit and an upper tracking rate, and why do we need this? We need upper tracking rate because when our patients go into atrial tachycardias or atrial flutter or atrial fibrillation, and we are aware this happens at extremes of age, you don't want rapid ventricular pacing in response to that. The upper tracking rate, the maximum rate the ventricle can be paced in response to sensed atrial events. The upper tracking starts with every ventricle sensed or paced, and we have to, as I mentioned, the pacemaker will never violate what we teach it. So VP can never occur before the upper tracking rate interval expires. So while this is the lower rate interval, this is the upper tracking rate that it cannot be violated. It is 600 milliseconds VP to VP. So this means that it will never violate. The upper tracking limit will not be violated. It will always remain 600 milliseconds. It will do anything. It will prolong the PR interval. It will prolong the AC to AS to VP such that the upper tracking limit is not violated. So I will just show you in the examples which follow. Typically, it is programmed to 120 beats per minute. However, this is programmable. You keep it faster, higher rates in young active patients, and elderly, you may want to program it to a lower rate. And just as before, now when you are having a dual chamber pacemaker, there are more refractory periods which come into operation. There is a ventricular refractory period which begins after a ventricular paced or sensed event. There is a post-ventricular atrial refractory period which begins after a ventricular event. And we will talk about the total atrial refractory period. These are sensed on separate amplifiers, the atrial channel and the ventricular channel. So ventricular refractory period we've already discussed. It's same as for a VVI mode, starts with every ventricular event. Events in the ventricular refractory period do not affect VA interval. Now we have to always remember that there will be sensing taking place in the refractory period, but the sensing taking place in the refractory period do not reset the timers. They just sense it and keep it there for us to see that an event has taken place, and it keeps it but does not change it. This is something which we really need to discuss, because this is where the next slides will talk about what is called PVAR. Now, retrograde P waves. You should remember that if the AV node is not refractory during a ventricular event, the ventricular excitation can be conducted back into the atrium as retrograde P waves. This is possible in both complete heart block as well as in sick sinus, we are aware. The retrograde P waves may be sensed by the pacemaker and initiate an AV interval followed by a V-pace. So this is what results in a PMT, which is one of the endless loop tachycardias. So I will show you here. Post-ventricular atrial refractory period, it starts with every sensed or paced ventricular event, including refractory sensed events. It renders the atrial channel refractory and has no effect on the ventricular sensing. It is largely intended to prevent the sensing of retrograde P waves by the atrial channel. The atrial events sensed in the PVAR do not start in a sensed AV and are marked as atrial refractory. So once quickly, after there is a V pace, there is a post-ventricular atrial refractory period. It could potentially happen that this V could go back into the atrium, which can be sensed and will be sensed as atrial refractory. This is extremely important because if this was not sensed as atrial refractory, if this was sensed as sense, it would initiate an AV interval and pace the VP, and this would now become a pacemaker mediated tachycardia. That's the importance of having a P1. Important point here, and I think we need to discuss this, is the total atrial refractory period. Now, as we mentioned, the atrial channel is refractory during the AV interval. It is also refractory during the PVARP, as I just mentioned, and both of them together make up for total atrial refractory period. So the sum of AV interval and post-ventricular atrial refractory period is the total atrial refractory period. During this total atrial refractory period, no sensed AV will start for events which are sensed in TARP. So there can be an AR which will come here, and that's important because if your patient has an atrial tachycardia, you want it to be sensed because only then will mode switch take place. However, that AR, since it's not AS, it will not initiate a AV interval. It's extremely important to understand this point, that total atrial refractory period is a point in time in the timing interval when the atrial channel is refractory. It will sense the events as atrial refractory, but will not initiate an AV interval. This TARP will be never violated. As a result of this TARP, a lot depends on your lower rate, your upper tracking rate, actually your upper tracking rate, and how is the upper rate behavior going to be. You may want to change the TARP sometimes by changing the AV interval or changing the PVAR if you want sensing to take place if the patient goes into something called 2:1 block or a Wenckebach operation, as I will just show you. I've already spoken of the blanking period. It is the first portion of the refractory period when sensing is completely disabled. It is to prevent the sensing of the pacemaker stimulus after potential repeat sensing of the same intrinsic waves and crosstalk, as Dr. Shafiq just mentioned. There will be, after an atrial spike, there is an atrial blanking. There is also a post-atrial ventricular blanking, because you don't want this A spike to be sensed in the ventricular channel and inhibit ventricle. After the ventricular spike, there is a post-ventricular blanking, and there is also a ventricular blanking. And these are the timing intervals which I have just already spoken to you about. So this is just a diagrammatic representation of the same. And this is how it operates. There is the A channel, the V channel. After an atrial pace, there is the AV interval. During the AV interval, the atrial channel is refractory to any events. Then after the expiry of the AV interval, there is a V pace. As soon as there is a V pace, there is again a timing interval called the PVAR, during which the atrial channel is refractory to any sensed atrial events. Thus, this together makes up the total atrial refractory period. During this time, if there is any event sensed in the atrium, it will not pace the ventricle. After the V pace, there is also a ventricular blanking and a ventricular refractory period. And this is how it goes on. I think we have already spoken upon the modes. It can either be ASVS, as you have already seen. It can either be APVS if the patient has good intrinsic conduction, as you just saw in the case which Dr. Shafiq showed you. There can be atrial sense ventricle pace, which is called P-synchronous atrial tracking. This is what typically happens in patients with complete heart block. But when you see this and you interrogate the patients, which you must do yourself, you should look whether the patient actually is having intrinsic conduction has resumed and you are unnecessarily pacing the ventricle, which should not happen. A mention about DDI mode. So DDI means dual pace, dual sense, inhibited. So this is largely what is a non-tracking mode. It is not going to track. I told you a D means P synchronous tracking. I means non-tracking. So it is a AV sequential pacing without atrial tracking. Atrial sensed events will not begin a sensed AV interval. Atrial sensed events inhibit atrial pacing. Ventricular pacing rate cannot increase beyond the programmed lower rate. What happens when you switch the mode switch on in patients when there is atrial tachycardia? The patient from a DDD mode will switch to a DDI mode when it will see a lot of atrial events on the atrial channel, which can be AS as well as AR. It will switch to a DDI mode. VDD mode is a mode ventricle pace, dual sense, and it will have dual inhibit and trigger. So it is a sensed intrinsic atrial event, starts in SAV, as you can see here, a P synchronous tracking. However, it cannot pace the atrium. Always remember, a VDD mode is not the choice of mode in your patients of sick sinus syndrome because it will not pace the atrium. Dr. Shafiq has already discussed much about crosstalk. So for the want of time, I will not go. But one point which you must remember of crosstalk, sometimes which you may encounter and see in Holters, is if you see this, there is an atrial spike which has been sensed by the ventricular channel and it is inhibited. The ventricular channel has been inhibited. This can sometimes be a cause of syncope. Remember, one way to diagnose crosstalk is taking place is that this event, crosstalk, always takes place only during an atrial paced event. Atrial sensed events do not cause crosstalk. So that's how you can diagnose on a Holter. And so as to combat and overcome this, there is called ventricular safety pacing. As I think he has already said, one way to always remember, it is called 110 millisecond phenomena. Whenever you see on a Holter that there is a AP followed by a VP at 110 milliseconds, you should think, is this ventricular safety pacing taking place? That's exactly what you can see. AP at 110 millisecond, there is a VP. The last part of my talk, which I will cover, is upper rate behavior and upper tracking rate. So I told you it never violates its rates. So the upper tracking rate prevents the ventricles from being paced at high rates. It can never be paced faster than the upper tracking rate in response to sensed atrial activity. And the upper rate interval is given priority over other timing intervals. What does that mean? That means that it will modulate and change the other intervals. I will show you. It will prolong the AV interval such that not to violate its upper rate interval. So we already mentioned that total atrial refractory period is a very integral, very important point that we must understand, because it is during this, it is this value which will tell us how to program the device, because it is operational in tracking the atrial rates, because in this time, no atrial sensing is going to be tracked. So this is the total atrial refractory, which is a sum of AV interval and the P-VARP. I have already mentioned to you, the atrial channel is refractory. I told you it will not start an AV interval. So the TARP, I have told you, you calculate by the AV interval and the P-VARP. Any atrial event which is lesser than TARP, or lesser than TARP in milliseconds or faster than TARP in rate, will result in every other intrinsic atrial T wave falling in the TARP, as I will show you. So here, so this is a sensed AV. So since the atrial rate is lesser than TARP or in milliseconds, you can see this AS, the next P wave is refractory. So what has happened? Every other P wave is blocked. The patient has gone into a 2:1 AV block, which you don't want. 2:1 AV block is something which you don't want, because the patient will become symptomatic. Suddenly from a rate of 130, 120, it will come to 60. So it occurs when intrinsic atrial rate exceeds the TARP rate and results in block of atrial intrinsic events in fixed ratios. I just showed you this. So every other P is falling within the P-VAR, hence it does not initiate a sensed AV interval, it is blocked. Then this is the next AS initiates the AV interval. And this is a 2:1 AV block in operation here, as you can see. You don't want this. We have patients who go into Venkiback operation. In fact, when you implant a pacemaker on the table many a time, because CHB patients are having high atrial rates and they are on a temporary pacemaker, when you connect the pulse generator, you will see Venkiback in operation. It occurs when the intrinsic atrial rate lies between the upper track and the total atrial refractory period. Because it will not violate the upper tracking rate, it results in gradual prolonging of the AV interval until one intrinsic atrial event during the TARP is not tracked. So this is what is happening. So this is sensed AV. So just after the P happened, it is asensed. It initiates a sensed AV, but it cannot violate its upper tracking rate. Hence, it prolongs the AV interval. Then there is a VP. It initiates a P-VAR. The next sensed P is within the P-VAR, so it is blocked. So this is how the Venkiback operation comes into place. It keeps repeating itself. So whenever when does 2:1 AV block happen? When the atrial rate is more than TARP. When does Venkiback take place? When the upper tracking is less than atrial rate, which is less than the TARP. Surely, Venkiback is preferred because there are fewer symptoms and warning to us. You should remember that 1:1 tracking occurs when the patient's atrial rate is below the upper tracking rate. That you have understood, because otherwise a sum will fall in the P-VAR. Venkiback will occur when the atrial rate exceeds the upper tracking limit, but is less than the TARP rate. Because as soon as it exceeds the TARP rate, it will cause 2:1 block. The ventricular rate will never be violated. It will never violate the upper tracking rate. There is some difference between upper tracking and upper sensor rate. In the upper tracking rate, the ventricle can never be paced at a rate higher than the upper tracking. Upper sensor is the maximum sensor indicated rate, and the atrium can never be paced at a rate higher than the upper sensor rate. So that's the difference between upper tracking and the upper sensor rate. I think I would like to conclude here that we must spend time on doing the CID interrogation ourselves, because there is so much which happens in the timing intervals, and it's a good idea to relook and recheck the pacemaker, as I just mentioned, for the best benefit of the patient. Thank you so much.
Thank you, Aparna. Great talk. As you mentioned in the beginning, this is something that should take 1.5 hours, and you've done a commendable job in compressing it. But this is something that also is quite difficult to grasp in the first this thing, and we must. I mean, I would encourage all the fellows to keep reading and discussing various intervals among themselves, so that you remember. Otherwise, it's very difficult to remember all these different intervals and different operations and complex interactions between them, unless one discusses them very often within the.
I did not discuss about auto P-VAR because of lack of time. I would like you to touch a little about auto P-VAR here in the time.
Yeah, okay. I think there are so many things that can be discussed, but all of these take 5 minutes each. So any questions in the chat box?
No, I don't see any questions in the chat box. Can I just make a comment here?
Please.
Most programmers, just for the fellows and postgrads, the programmer oftentimes comes back and gives you a warning if you're doing a wrong programming. For example, if you're exceeding the TARP limits, the pacemaker will come back, the programmer comes back and gives you a warning that this patient will start Venkibacking at 110 or 115. So if you do this yourself, you're not taking very many risks. You're getting a warning that you're doing something wrong, review what you're doing. So, there's this sort of mental block among many postgrads and fellows of, they're worried about programming pacemakers and trying to, don't be so worried. It just gives, if you're doing something wrong, the pacemaker will give you a warning. The programmer will come back and give you a warning oftentimes. So you can review your parameters that you're setting.
Absolutely.
And a lot of sorry, as Aparna was saying, there are a lot of auto functions incorporated now within most pacemakers and programmers. So there's an auto P warp, there's a other thing, you know, so you can juggle the parameters to suit the individual patient without too much of a risk.
And taking on from there only, I really want to urge the fellows and the young to engage themselves in the programming. And I'll give you a little example here. A couple of years ago, we had a patient, elderly lady, who came into the OPD, and she came with a blue eye, and she had a dual chamber pacemaker. And the pacemaker programming was done by the tech and given to us that everything is absolutely fine. At that point in time, she was A sense, V sense. So it was that, how can it be everything is fine? And you have to believe this, that we got the X-ray done, and there was a 1-inch separation of the RV lead, and it was just on a string, it was attached. So at that point in time, I don't know how they measured the impedance, what they did. So you must see the pacemaker programmings yourself. They are so value addition to the patient.
Especially in post-operative cases where the pacemaker has been reprogrammed during the surgery. Oftentimes after the surgery, the parameters are somehow not programmed appropriately. And it's very wise to do this yourself. I absolutely second what Dr. Aparna is saying.
Sure. That was a great short, but still very easy to understand.
A dry theoretical topic made interesting and practical. Good job.
Yes.
Thank you, sir. So I think if we go ahead, may I request Dr. Amitesh to present his case? Amitesh, maybe you should have one device switched off, otherwise it will keep echoing there. Is Shafiq sitting with you?
Go on full screen, please.
Am I audible?
Yes. But please make it full screen.
Am I audible?
Yeah, audible.
Yeah, you're audible, Amitesh, but please make this full screen.
You can start.
Amitesh, can you hear us?
Go on to slideshow, Amitesh, please.
I think maybe he has some audio issue. He can't hear us or what? Aparna, can you call him?
Amitesh, go to slideshow. Can you hear us? No.
Hello? Hello? Yeah, this is Shafiq. He's with me.
We can hear him.
Yeah. जी मैम नहीं वो तो मैंने बंद ही कर दिया था नीतीश सर की साथी तो उन्होंने एको कर रहा था ना उनको चल ही नहीं रहा वो दे एक मिनट अप्लाई फिर शुरू करता हूँ उसी को हाँ जी मैं फिर से मैं तो अभी ट्राई करता हूँ आपके पास पेन ड्राइव है सर हाँ तो दे दो मैं अभी प्रेजेंटेशन मेरे पास नहीं है अरे
Shall we otherwise go ahead with the other?
We can. I can do my presentation in the meanwhile.
Right. Yeah. He has to stop sharing screen.
Right.
No.
Amitesh, you can stop sharing. Yeah.
No, sir, he's ready. He's ready.
Okay. Okay. All right.
Amitesh, are you ready? Amitesh, can you hear us? Hello. So I think,
You can hear him. Either you can ask him to start talking.
yeah, I just,
उनका चल ही नहीं रहा meditation.
Then why is he not responding to any of the questions? I mean, that it's not understand. I don't understand
Just
that.
totally disconnected.
okay, no problem. Sir, I think you can do it. I'll connect with them and help.
Okay.
Yeah.
Shafiq?
But he has ask him to.
No, I'll just.
कुछ नहीं करना क्या है? जी मैम. Can they see my screen? जी मैम. ठीक. Stop sharing. Stop sharing.
Okay, Anil, you can start.
Yeah, sure.
Hello.
So can you
Yes.
see my slides
See
now?
and hear. Yeah.
Okay, great. So good morning, everybody, once again. Now I will discuss ECG interpretation of paced rhythms, and this will largely be a real ECG based presentation. And because I think the previous speakers, Dr. Aparna and Dr. Shafiq, have done a great job, and I will show some of the examples of what they have already discussed. Now, as Dr. Aparna mentioned, the pacemaker basically is supposed to stimulate the heart muscle whenever there is no intrinsic electrogram, or the P wave or R wave is not forthcoming. Then the pacemaker delivers impulses to atrium or ventricle or both, depending on what type of pacemaker we have implanted, whether it's a single chamber, dual chamber, or biventricular, and it paces or stimulates the myocardium. And it has a sensing function as well, that it can sense the intrinsic electrogram. Now, this strip is the most basic pacemaker operation, which we can see that there is a pacemaker spike, which stimulates the ventricle in the first beat. The second beat is also paced beat in the ventricle. The third appears to be a spontaneous beat, which has a P wave and a QRS. So it is sensed correctly, and the next cycle starts after a delay. Again, it's VVI 60, so it waits for a second. That's 5 large squares, and again delivers a ventricular impulse, because a VVI, simple VVI pacemaker, and it's pacing every 5 large squares, which is an interval of 1000. So the pacemaker, you can see that it's a normal VVI operation, which has a pacing interval which is about 1000 milliseconds. And it has an escape interval that is between any sensed QRS and the next paced impulse. That's called a escape interval. And normally, if we don't have any special algorithm program, the pacing interval and the escape interval, they are same. But Dr. Aparna mentioned about hysteresis, which allows which allows the ventricular rate to drop to more than the lower program rate, and that is the escape interval is longer than the pacing interval, and that's called a hysteresis operation or hysteresis rate, which can be lower than the programmed pacing rate. So here the pacing interval and escape interval are different, and escape interval can be longer depending on whatever rate we have programmed. So in this example, we have VVI 60 and hysteresis rate at 50. So the escape interval is longer than the pacing interval. And this is another example of pacemaker operation, which is basically a AI pacemaker. So as we can see in the beginning of the strip, we have atrial pacing. So the atrial spikes, which produce a P wave, and subsequently patient has intrinsic P waves, and the pacemaker gets inhibited. So this is a simple AI operation. Now, as Dr. Aparna mentioned, there are 4 types of operation possible in a dual chamber pacemaker. One, of course, is a atrial sense ventricular pace. This happens when the patient has a complete heart block. So every P wave is tracked, and it triggers the ventricular impulse. So patient will have a sense V pace operation. That is when the sinus node function is normal. If the patient has AV block as well as 6 sinus syndrome, the patient will have a pace, V pace. That is both A and V are paced. we can have a pace V-sense that happens in patients who have 6-Sana syndrome where only atrial pacing is required. So we have a pace V-sense operation, and we have A-sense V-sense when the patient has intermittent problem, either intermittent sinus pauses or intermittent complete heart block, that a large part of the time the patient has a normal A-sense V-sense, and A pacing and V pacing comes into play whenever the patient requires it. Now, the biventricular pacemakers are increasingly being used in patients who have heart failure and wide QRS, particularly left bundle branch block. And there the morphology is somewhat different. The pace morphology is somewhat different. So the unpaced patient will have LBBB, and in the paced operation, if we have only RV pacing, then as you can see, the QRS complex is very wide, and we have a LBBB type morphology again. But in the biventricular operation, you will find that the QRS is relatively narrow, and the V1 will have a positive wave, and the lead 1 will have a negative wave as well, because we are now operating we are pacing from the left side also. So lead 1 and AVL may have a negative wave, and the V1 will have a positive because we are pacing posteriorly and the V1 is anteriorly. So this is a feature of a narrower QRS complex and a positive wave in V1 and a negative wave in lead 1 and AVL. These are features of biventricular pacing. And that's another ECG of the precordial leads in biventricular pacing. You can see that the QRS complex is much narrow compared to the right ventricular pacing. And we see a positive wave in lead V1. So that's a feature of biventricular. That's how you recognize that the patient has a biventricular pacemaker. In many patients, the RV and LV impulses will be simultaneous, but sometimes we program a gap between the two with LV first or RV first, and there's sometimes you can even see them separately. They're not seen here separately, but if the interval is more than 30 milliseconds between the two, if it is 40, you will see an interval of 1 millimeter. So you can see RV and LV impulses separately, and you can definitely make out that's a biventricular pacing. So let us come to some examples of paced rhythms. Now, this is a patient who sometimes, these patients, they come to us that their GP has told that the pacemaker is not working properly or is working intermittently. But when you examine, you find that the operation seems to be completely normal. So we have 3 paced rhythms, and then a spontaneous rhythm comes in, which is a sinus conducted, 3 impulses, in fact. And then gradually the patient, the bradycardia, and the patient goes back to the VVI pacing. So this is a normal VVI pacing, but sometimes it may create confusion in the minds of patients or GPs that it's not working properly. But this is a normal VVI operation where you have paced impulses and then the spontaneous comes in. Spontaneous can always come in before. If the pace comes in before or before expected, then we call it undersensing, as I will discuss subsequently. So the pacemaker malfunction on ECG can occur for a variety of reasons. It could be equipment malfunction or some algorithm malfunctioning, or it could be inappropriate programming. And the ECG changes can be very subtle or sometimes even absent. And we must learn to recognize these malfunctions because it can be life-saving if detected early. So the different malfunctions on the pacemaker on the ECG that we can see could be either problem with the sensing, it could be undersensing, it could be oversensing, because as we have been discussing that the pacemakers are supposed to sense the intrinsic algorithms, intrinsic electrograms correctly. And if there is a problem with that, it could be undersensing or oversensing. It could be problem with the pacing, where again, it could be failure to capture, which is much more common, or it could be output failure as well. And there could be some ECG patterns which are classified as pseudo malfunction. We saw one of them earlier, and there could be pacemaker induced dysrhythmias, which could be even like pacemaker tachycardia, etc. So coming to some representative ECGs, what is this that we are seeing? We find that the first 2 complexes are paced ventricular complexes. The third one is a sensed complex with both P and QRS normally seen. And then we see a pacemaker spike, which should not have been there, because once the pacemaker senses this QRS, then it should not give a spike here. And then next, again, after the next QRS also, there is a spike, which gets captured. This one, this one did not capture the third spike because it's falling in the refractory period when the ventricle is refractory. So it's just after the QRS complex in the ST segment. A ventricle cannot be captured at this time, but this one has captured. So anyway, the point I want to make here is that this QRS should have been sensed, which was not sensed, and the pacemaker has given a spike. So this is a example of undersensing. And these are the marker channels which are available in all the pacemaker interrogations, where we can see what exactly the pacemaker is doing. Now, so this is what's happening, that the intrinsic beat is not sensed and the pacemaker delivers a pacing impulse. It can happen when the pacemaker is either programmed in asynchronous mode, or there is some poor lead contact, or some other programming issue that we have not programmed the sensitivity properly. So if there is undersensing, we need to increase the sensitivity, that is reduce the sensing threshold. So that is something that we can handle with appropriate programming. Now, what do we see here? This is another interesting ECG where we can see, if we look at the start from the beginning, we find that there is a paced rhythm going on in the ventricle. So it's a VVI pacing going on. The first 3, 4, 5 beats are paced. And the 6th beat, we see there is a QRS complex on top of which there is a pacing spike. And 6th is without a spike. So this is a normal one. So what we see here is that the 6th and 5th, I mean, these two are very, very similar. There is no distortion of QRS complex by this pacing spike. Now, this may be called undersensing by some on the routine inspection, because the spike seems to be falling on the QRS, but because it's not modifying the QRS in any way, it's probably a bit too early in the QRS, and it can sometimes happen that the QRS was not sensed by the time the pacemaker delivered a spike. So this is called pseudo undersensing, that the spike falls on the QRS, doesn't modify it, is in very early part of the QRS complex. So that's pseudo undersensing. Now, what is this? This patient has a VVI pacemaker, which is programmed at the rate of 60. And what we see here is that the first 2 spikes are occurring at exactly 1000 milliseconds, which corresponds to the rate of VVI 60. Then we have a spontaneous beat, and then we have another spontaneous beat at a very long interval, 1500 milliseconds, 1560 milliseconds, and another beat at.
Sorry to interrupt you.
Yeah.
Very sorry to interrupt you. Your screen, I think, it appears and disappears. I do not know why, but it disappears now somehow, and then appears.
Does
again.
it?
Yeah, we're not having your screen right now.
I don't know why it does that, but.
Okay, I can see my screen.
Yeah, you
clearly.
must be seeing constantly, but here it goes.
Okay, should I just a
Nothing
minute?
to do with the battery, no?
No, nothing to do with the battery also, and maybe I can stop share once. Oh. Yeah, it has to do with the battery because it's going very low. Just a minute. Give me a minute.
Yeah, sure.
Yes, we can see it now.
Is it okay now? Okay, great. Thanks. So was it happening for many slides?
But last 2 slides?
Last 2 slides, okay. So here we can see that the first 2 beats are paced beats, and then we have a spontaneous and another spontaneous, and there is a large gap between the 2 beats, 1560 milliseconds and 1400, which doesn't go with the VVI 60 because we should not violate the low rate interval, as Dr. Aparna mentioned. So what's happening here is that if you look at the marker channels, you find that there is another sensed event here when there is nothing here. So obviously there is some lead noise which the pacemaker has sensed and reset the clock. So it's not pacing, it's not delivering spikes. So that is called oversensing. And that when there is nothing, no activity, but the pacemaker gets inhibited. So it's sensing some kind of noise, which could be within the pacing system, or it could be outside the pacing system, within the body or outside the body. So oversensing can happen because when there is a electrical signal which is being inappropriately recognized as native cardiac activity and the pacing gets inhibited. It could be some intracardiac signal, it could be extracardiac, which could be skeletal muscle activity, or it could be some lead noise, or sometimes it could be outside the body, that is electromagnetic interference. Now, coming to another ECG, what is this happening? We find that there are, so the question is, which of the following is normal out of, you see, there are four things: atrial sensing, ventricular sensing, atrial capture, ventricular capture. And of these, only one thing is normal. All the other three are abnormal. So let us see one by one. Is ventricular capture normal? Certainly not, because you see native QRS occurring at a very slow rate. So ventricular capture is certainly abnormal. Ventricular sensing is also not normal, because after this QRS, there is a spike, which should have been delayed. So it is also abnormal. So ventricular function definitely is abnormal. Atrial sensing appears to be normal because after every P wave, there is a spike delivered. So atrial sensing is normal. Is atrial capture abnormal? Yeah, after the atrial spikes, we don't see any P wave. So other than atrial sensing, everything else seems to be wrong with this particular pacemaker. So what's happening here? In this ECG, again, we see that the patient has a dual chamber pacemaker. There are two spikes visible for every heartbeat, but it's certainly not capturing the ventricle, because we can see ventricular rhythm at a very slow rate. That's a non-captured native ventricular rhythm. So patient must be having AV block or 6 channels, whatever with AV block, but definitely AV block is present. But we can see paced atrial rhythm. So atrial pacing is okay, because after atrial spikes, we can see a P wave in lead 2. So atrial pacing is present, but definitely there appears to be a ventricular lead dislodgement, because the ventricular signals are not being sensed also. So this native QRS is not being sensed, and the pacemaker delivers spikes, and neither is ventricular capturing. So this appears to be ventricular lead dislodgement here. Some noise is coming. Can you please everybody be on mute? What do we see here? In this ECG, we see that the patient has a dual chamber pacemaker. There are two spikes for every heartbeat, but the atrial capture is not present. So we can see that the atrial spike is not producing a P wave. So this is a example with atrial non-capture. So failure to capture can happen when there is a electrode, lead displacement or lead fracture, or sometimes with MI and exit block, or with the electrolyte imbalance also sometimes we cannot capture. Now this is another interesting case where the patient has got a DDDR pacemaker implanted, and this is the post-implant ECG. Now the interesting thing here is that we find that of course, it's a pace, V pace, as we can see in lead 2, there is a V pace also, but the QRS complex appears to be positive in lead V1, which is not usually the case. When we have a dual chamber pacemaker, we expect a LBBB type pattern with a negative complex in V1. And positive complex can happen in several situations. One is when the lead it perforates the RV apex and starts pacing on the left side in the pericardium. It can happen when you go across the foramen ovale and pace the left ventricle. It can happen when you insert the lead in the coronary sinus inadvertently. So what we see here is that it appears to be normal here in the in the AP view, but when you take a lateral view, you find that the lead has gone posteriorly. So it's obviously in the coronary sinus and one of the coronary sinus veins. So that's why it's producing a positive in V1, which is anteriorly. So if you pace the ventricle posteriorly, you will produce a positive wave in lead V1. And the lead was then repositioned, and now we have the typical pattern of the RV pacing with the left bundle branch block morphology. And this is the correct position on the lateral view. You can see it is positioned anteriorly. So so this is something which we must remember, that in the AP view, you cannot always make out where your lead is. If you see in both situations, it appears to be in the same position. So whenever we implant a pacemaker, we must check in the deep paleo or if possible lateral view that your leads are anteriorly placed, both atrial and ventricular. They should be anteriorly, they should be pointing anteriorly. That's very, very important. That's another interesting ECG where patient has a VVI pacemaker and there is no pacing output. Patient has bradycardia, which can happen when the battery is at the end of life, or it can happen with the complete lead fracture, as Dr. Apana mentioned, 1 inch gap between the, so patient has complete lead fracture, there will not be any output or any spike. And it can happen when there is oversensing and inhibition of the pacemaker. Another interesting ECG, so if you look at only one lead, for example, if you look at the bottom strip here, you may find that there is no output intermittently, there is a failure of output. But if you look at other leads, you find that there are spikes which are not visible in lead 2. So you can see that in V4, 5, 6, there are clear spikes which are not capturing. So there is an intermittent loss of capture, not the failure of output. So this is important to differentiate. Then lastly, some pseudo malfunctions. So we can have on the ECG is given to you, sometimes a Holter is given to you, which may show this kind of pattern. And one may wonder as to why this is happening here. It sometimes happens that the patient is on Holter also in the ward, and somebody comes to check the pacemaker, either puts a magnet or does it with the programmer that also sometimes has a magnet, and all these different operations get recorded in the Holter. And when the Holter is presented to you, wonder what we are dealing with. So what we see here is a magnet rate operation. When you place a magnet, the pacemaker starts pacing at a faster rate, insert at certain rate. Every manufacturer have their own pattern of magnet rate. So that is something to be understood. Then, as Dr. Apana mentioned, if the atrial rate exceeds the TARP rate, patient may go into 2:1 operation. And this is a pseudo Vankeback. When the heart rate is between the upper tracking rate and TARP rate, we have a Vankeback type of operation, which is called pseudo Vankeback because in pacemaker, you can't have true Vankeback. So it's a pseudo Vankeback operation. Then PMT intervention, sometimes the pacemaker goes into endless loop tachycardia because the ventricular pacing produces a P wave, which is retrogradely conducted, and that can be sensed by the pacemaker to trigger another QRS. So that goes into endless loop tachycardia or PMT. And the pacemakers have their own algorithms. I don't think we have time to discuss all these, but pacemaker can intervene themselves and break the PMT. And lastly, on the Holter, again, you can see changing heart rate depending on the rate response. So if a patient has a VVI pacemaker, you may find the patient suddenly climbs stairs and you find the heart rate accelerating. So all these are pseudo malfunction, which to the uninitiated may appear abnormal, but they are normal operations. And that's another example of pseudo malfunction, what we discussed in the previous case, the MVP. So what happens here is that, like this pacemaker is with the MVP programmed. And if one P wave is not conducted, the next P wave is paced with a short PR. And then if another P wave is not conducted, then the pacemaker again paces with short PR, but then changes mode to DDDR mode. In the beginning, it is AIR, but it changes to DDDR. And whenever subsequently, what happens when it keeps checking, and lastly, when it can switch back to from DDD to AAI, because periodically it will extend the AV delay, and if it senses a native QRS, it will then change to AI mode. So I think I think we don't have much time left now. So I think I had some more examples, but I think we can stop here and take any questions if there are any. Thank you very much.
Anis, to come in?
Yeah, good presentation, Dr. Saxena. I think you have covered all the basics of dual chamber pacemaker. Maybe a little more explanation for everyone to understand about CRT pacemakers. So just for the students to maybe take home message. What are all the problems you can like expect if there is undersensing in a patient with I mean, clinically, what can happen to the patient if there is undersensing in a dual chamber pacemaker versus if there is undersensing in a complex device like CRT? How is it materially or clinically different?
I think one of the main problem that it can be life-threatening actually, particularly ventricular undersensing. So sometimes, and we must remember this, that sometimes, when the patient is undergoing surgery, we program it to non-sensing mode, like asynchronous mode, and patient goes back to, after surgery, patient goes back to ward, and the pacemaker is in asynchronous mode. Some of the spikes can fall on T wave and induce ventricular arrhythmias. I have heard about such an event happening in a patient. That patient actually had ventricular fibrillation and died. So it's very important. Undersensing can create havoc if it is ventricular undersensing and it paces in the vulnerable period of the T wave. Atrial undersensing is less troublesome. It can sometimes generate PMT because if the P wave is not sensed and subsequently it paces in the atrium, which is not captured, but then the subsequent V pulse can be conducted back, and it's one of the initiating mechanism of PMT. So I think it's very important that sensitivity setting should be normal.
I think we about the clinical implications of undersensing. Sometimes we program in VO mode and then we forget about it. That is very important.
Yes.
And also, like during crosstalk window, like why do we like have a very short interval? If you can explain it, I'm sure you will be able to explain it better. After sensing in the crosstalk window, why is that the ventricle is spaced at a very short interval?
In the safety pacing.
Yeah, the safety pacing.
In the safety pacing, now I'll mention about safety pacing. So the AV interval of a pacemaker is divided into three parts. The most initial part is the blanking, where nothing is sensed. The second part is called crosstalk sensing window or noise sensing window, where if any impulse is sensed, the pacemaker would not know whether it's a native QRS or some noise. So it gives a safety impulse. And it is given, as Dr. Anis mentioned, at a very short AV delay of around 80 milliseconds. And that what I am told is that it's a short AV delay to make it identifiable on the ECG that it's a safety pacing, so that we can identify that safety pacing is going on. There is some abnormal noise being sensed by the pacemaker.
Could it also be due to the same mechanism? Like if you pace it little later, it may fall on the T wave of the sensed QRS complex and maybe produce a VT or something. I mean, I'm just wondering now.
Because T wave, that happens at a very long, in the descending part of the T wave, towards the end of T wave. So that would be a very long interval. Usually AV delay is not that long. So I don't think 80 and 150 will make much difference there. But that's what I have been told, that it is just to mark it on the surface ECG, on Holter or ECG, that safety operation has taken place.
Okay, excellent. Thank you, sir. Anything to add, Dr. Abarna? You wanted to say something? Yeah.
I just wanted to add one thing which I did not cover in my talk because of lack of time, and the fellows must know that whenever a patient has a pacemaker and comes with a tachycardia and you see that there is ASVP taking place at the upper track rate, it should ring a bell that is this a pacemaker mediated tachycardia? Because whenever tracking takes place at the upper track rate with a pacemaker, you should think, and then you should look back what initiated it. If it is AV dyssynchrony, it is always a loss of AV synchrony, as Dr. Saxena just mentioned. Loss of AV synchrony for whatever reason can initiate a PMT, which is operating mostly at the upper track rate. You should think it is PMT. At that point, you should look back into the P-warps.
Yep.
You should extend the P-warp there. That is one place you want to extend the P-warp. Typical P-warp programming is around 300 milliseconds. We don't go less than 260, 270. But you may want to extend the P-warp in your patients where you see there is a PMT taking place.
Dr. Nabha, do you want to have the talk now, or you want to?
No, I think Amitesh, are you ready to do it quickly, or?
I'll do it quickly.
Yeah. Just that he's prepared, and we can, being informal, we can give him 10 minutes too.
Am I audible?
Yeah,
Yes.
Amitesh, can you just go full screen, please? You're audible, no problem.
Good morning, respected teachers and my dear friends. Today I'll be presenting a case about a 55-year-old gentleman with a diabetic
Please go full screen, no? Sorry, please go full screen, no? On the right lower corner of your screen, I can see there is that icon. No, right lower corner
Going
of
to
your.
presentation mode.
See,
Dr.
are you there?
PowerPoint presentation mode. Yeah.
Now where 50% is written, go down and see on your computer, right lower corner, there is 50% written of your battery. Just left to that, you can see right lower.
I've done that. I've done that.
This one. Click it. Okay, no problem. I think we'll go ahead then.
Allah, go to slideshow.
So this was this patient who presented with bradycardia, a heart rate of around 25 per minute, associated with oliguria, hypotension, a systolic BP of around 80 millimeters mercury, and associated giddiness with nausea and vomiting. So the initial investigations revealed a hemoglobin of around 10.5, creatinine of 5.1, sodium and potassium were normal, cardiac enzymes were normal. So this patient's ECG is there, and it revealed a complete heart block. So taking into consideration the hypotension,
We can't see your slides. At least I cannot see. I can see only the first slide, 55 years male, diabetes, hypertension.
It's my slides. I am not able to see slides.
Just try to see if there is another screen open. Just go to the Zoom, share another screen with the full.
Yeah, I'll do that.
I think you can just quickly take Shafiq's computer if you've loaded there, and that will resolve everything, because maybe your computer is hanging.
Yeah.
We have very little time left, and just show the case. We won't have much of a discussion now. And please show it from Shafiq's computer, Amitesh.
Yes, ma'am.
Is that ready?
Yeah.
Good. So you can just switch this off and share it from there. Stop share here.
Okay, it doesn't matter if it's not full screen, you can proceed.
Amitesh, proceed, please. I think there are severe technical glitches wherever these guys are.
This is, I think, 4G internet at play.
Is it now visible, sir?
Yes, we can see it now. Please go ahead.
Right. So there was evidence of CHP, and we,
Two devices open, a lot of echo.
without wasting much time, we shifted the patient to the cath lab for an urgent temporary pacemaker. As you can see, there's a prominent R in V1. So when you have such a situation, there are a few things which come to your mind. You should be really worried. So amongst the causes of RV in V1 after right ventricular pacing, you can be looking at a lead perforation, or you can be placing inadvertently the lead in the coronary sinus, or perhaps you've gone through one of the septal defects into the LV and pacing the LV. And rarely in RV pacing, you can see. So the literature says the amount to be around 8 to 10%. So with this particular ECG, we saw the X-ray of the patient, and it was supposed to be displaced slightly towards the right. So as soon as you have a displaced heart, dextrocardia comes into the mind, and we thought we'll evaluate him completely. And so we went ahead with a detailed echo, and we had a good discussion with the pediatric cardiologist team as well. And we came to a conclusion that the central part, the cardiac axis is more central. So this cannot be a dextro, but can definitely be a mesocardia with no associated cardiac anomalies. We got an ultrasound done as well, which said that there's no normal spleen, liver, and it was normal situs and no apparent abnormality seen. So after the initial stabilization of the patient, we went ahead with the pacemaker implantation. So we had in mind that it's not going to be the usual way we do it. We have to look into the fact that the heart is mesocardic, and we made sure we prepared. So after taking the subclavian axis for the RA and RV, we took 2 axes. We went ahead. What we did was we shaped this, styled it into a large generous curve. This is not the usual way we do it, but because of this particular case, we went ahead and kept a large generous curve. So as you can see, once we put the lead with this particular curve, this was the AP view. Now, when you have mesocardia or abnormally like dextrocardia, you are looking at AP view, which is parallel to the spine, the RV. So this gives you a fair enough idea as to, when you're pacing, when you've put the lead, it should be close to the spine in RAO view. And this is the picture now which has come up is the usual way RAO looks in a conventional lead placement of the RV. And this was typically the LAO view. Now, LAO view usually is different because we are looking at the spine in a conventional way, but this is looking more anteriorly away from the apex. This is more towards the cardiac apex of that particular, in this particular case. So in LAO view, we fixed the RV lead, and we checked all the parameters. There was a good current of injury. The RV was like 10, and we had good thresholds. So we went ahead to put in the RA lead. So as expected, when you have normal atrial situs in either mesocardia or in fact even dextro, the orientation of the RA is usually the same. So we went ahead with the conventional way. We put an RA lead, and this was LAO, which is slightly a bit anterior, and we had good parameters after we fixed the lead. And there is a conventionally, we use active fixation leads, but sometimes in anomalies of the heart, you can have an issue. So this is just for a discussion that, if you have an optimal pacing site available, you active fixation leads just do it for you. So after we had fixed the leads in the respective chambers, the RA and the RV, we placed in the pacemaker, and we had good post-procedure parameters, P wave of 2.4 and R wave of around 11, good impedances and good thresholds. Coming to
bit about what we've done. So this is just an algorithm which was published in Angiology in 2006, which says that if you have an R wave in a prominent R wave in lead V1 after you put in a pacing lead, you can actually be looking at a few factors which can tell you if you're safe or you need to worry. Amongst this, the ECG that we have showed that the V transition, the precordial transition occurring before V3, V4. So this says you that you are pretty much okay with the lead in place. So there's a access point as well, including an absence of S wave in V1, we can in lead 1, sorry, which can tell you that you probably in the RV. A bit of the fluoroscopic anatomy normally that we see is in an LAO view. You know that if you're facing towards the the lead towards the spine, you're actually towards the septal side. If you're looking up, and so you're looking for more anterior, and if you are more on the posterior side, then it's no on the anterior side, then you're probably looking at the RV free wall. This is just the view which we as electrophysiologists take, where you know that the free wall touches the septum more towards from the anterior aspect, and this is just the anatomical structures that you have when you are in the RV. We are specifically looking at the septoparietal tuberculations because that is supposed to be the side where you have the septal lead placement. This is just fluoroscopic localization in RAO, and this is more of LAO. And these are LAO views to see if you are septal or not. The lead should look more up. If you're more anterior, then it should look like this. And if you're looking free wall, we have already discussed that this looks like this. This is the conventional RAO and LAO views for a conventional pacemaker. So we have had a few, few articles in the past. One was from Dr. Radhakrishnan from our institute on dextrocardia analysis of 25 patients. And there's a beautiful paper by Dr. Jayaprakash on pacemakers in dextrocardia. He's just described everything regarding dextrocardia, situs inversus, situs soletus. And these are the other facing therapies in dextrocardia, including the different indications that are there. And coming to our case, mesocardia, the cardiac axis is usually in the center with no deviation to either to the left or the right. This is how it looks in the CT and an MRI. And because it lies in the mid-sagittal plane, there is no apex. That's the reason they call it the dewdrop heart. And there's again a very nice paper on the pathologic anatomy of mesocardia, pretty old, by Morris Leff, 1971, which discusses a bit about mesocardia. Interested, you can actually read about it in this article. Yeah, thank you.
Yeah, thank you so much. So I think basically what Dr. Amitesh is trying to bring a point in here, that you should be ready for different anatomies. And before you go into the case, it's a good idea that you know what you're in for. So in this particular case, we were very clear that you should know whether there is any left persistent SVC also or not, because these are often combined with left persistent SVC. Remember, they are sick patients. They can't be on the table for too long. If you want to minimize your procedural complications, go in well prepared with what anatomy you are headed for. And whenever you have a situation like this, do you want to go from the right or you want to go from the left? So all these decisions should be taken well in time and not in the cath lab. That really makes your procedural outcomes better. So in this particular case, when we went in, it was that, we're headed for a long time. We took a lot of time. We prepared ourselves very well, prepared the patient well for the procedure because he was in HFpEF. And we were prepared to spend a couple of hours. And you know what happens when you go in? You're all in for surprises. It was 30 minutes and we were out. So you should go in very well prepared. That's the take-home message, that whenever you go in for an implant.
Aparna, you mentioned about left SVC. Can you give some tips and tricks as to how you do it in a left SVC?
Yeah. So whenever, first of all, is that in adults, we're just fortunate that the prevalence of left persistent SVC is a rarity. However, when those of you who are in a cardiac unit doing pediatric implants with congenital heart disease, left persistent SVC is a common find. Even then, in adults, you will see in about 0.5% of people that you may find left persistent SVC. So whenever you're faced with a situation of left persistent SVC, what comes to your mind immediately is that when you take your puncture from the left side and you see that your wire is going to the left of the spine, it is not crossing the midline and going to the other side, it should immediately draw your attention that you are probably dealing with a left persistent SVC. Now, the choices that you have are either you want to continue with the implant on the left persistent SVC. If you feel you're not confident, you will be doing nothing wrong in quickly changing your decision and going to the right. Remember, going to the right will be just as you are doing from the left. You will find the connection to the SVC and the right atrium and the RV. You can easily shift to the right. You don't have to be a hero that's saying that, no, I have a left persistent SVC. It's your first year post fellowship that I have to do it from there. So you can quickly shift to the right. However, you may have a situation where the patient may already have a problem on the right, or the patient is stable and you want to explore and you want to go in from the left. Having a left persistent SVC is no contra to doing the implant from the left persistent SVC. Yes, it will be a little longer. You may have to make double curves to enter from the left persistent SVC. Turn your stylet to enter the right ventricle. Entering the right atrium is simpler from left persistent SVC, but for entering the right ventricle, you will have to make a large curve of your stylet. Always try and take active fixation leads because they follow the course better. The only place where you may want to depend upon passive fixation leads is when you are dealing with very elderly patients and you are afraid that you may perforate the right ventricle. Outside of that, in our clinical practice, we've actually shifted completely to the practice of active fixation leads. So these are certain things that I want to mention that you can go ahead either side. And one point I want to tell you, which Dr. Saxena showed you in ECG, wherein he showed you the lead, the RV lead was pacing through the coronary sinus. So as a practice, when you are doing an implant and you are doing the implant from the left and you think that, wow, my lead is very nicely in the right ventricular outflow tract in an AP view, you should be sure whether it is actually in the coronary sinus. There are two things you can do. One, quickly go to the LAO view. You will know whether you're in the CS. Second, pull the slit back and let the lead fall down. If the lead is in your right ventricle, as soon as you pull the slit back, your lead will fall down. You should not want to screw if your lead is not falling down. That means that you are probably in the coronary sinus. So these are certain pointers that I think we wanted to speak from this here. And Dr. Yash has more experience, and sir says that he makes a small U-curve for entering the right ventricle from the coronary sinus. That's another tip that we all should take cue from, that from the coronary sinus, if your patient is having a left persistent SVC, make a U, like you have a preformed U, the atrial stylet. And that's exactly what he is saying, that Dr. Nabar says, using the atrial for the RV lead positioning. Perfect.
Sure. So since we are running out of time, Anis, a few comments from you, and Dr. Saxena, your closing comments.
I think nice case and also nice presentation by Dr. Anil Saxena. So to add to this, like with the septal positioning and the bundle positioning, like in normal pacemakers, I have found that, going for the mid-septal position towards the anterior margin of the RV in RIO view gives probably the best narrow QRS also. And this is also important in patients, probably in patients with heart failure, or even in patients with diastolic heart failure, to have a narrow QRS when they are not, when they are pacemaker dependent. So that's one thing I wanted to add. Other than that, now with the micra pacemakers, positioning the device on the septum is very, very important. So knowing the anatomy, as well as the fluoroscopic anatomy of the septum, as mentioned in the case, is interesting. I mean, you want to add anything to that, Dr. Aparna or Anil?
Yeah, no, thanks. Thanks, Dr. Anis. And I would like to, I think the time has run out. We are already beyond the scheduled time. So we had a very good session, and thank you all the participants. Thank you, Dr. Ashish, for giving this opportunity to us. And thank you, audience, for being there.
Thank you, everyone.
I think we can close the session. Thank you so much.
Sure. So I would say that Dr. Saxena and Dr. Aparna can teach a lot about the CIDs, but this time the brief clearly was keep it that the DNBs get their basics right. And I think they have helped us wonderfully to achieve that. Sure. So we'll keep meeting on first Sunday of every month at the same time. And let me thank the Fortis Escorts group and Dr. Anis and Dr. Asit Shah for sparing them time on a Sunday morning. Thank you very much.
Thank you.
Thank you, everyone. Thank you.
Yeah. Bye-bye. See ya.
Bye.